the NHS is a wonderful institution, but it is frankly not delivering the care our patients deserve any longer, and we have to change that.
Welcome to Health Chat, the UK's #1 health and social care podcast. We discuss the most important issues in the healthcare sector and the challenges our colleagues face from the front line of delivery to decision making in the boardroom. Join me, your host, Dr. Atif Ghaffar, as we speak with interesting people from across health and social care and bring you expert insight and discussion on the topics that matter most to healthcare professionals. Hi, welcome everyone to another episode of Health Chat. It's your host, Dr. Atif Ghaffar. Today I'm with Dr. Ron Daniels, who is an intensive care consultant based in the city of Birmingham. Ron is also the Chief Medical Officer for the UK Sepsis Trust, and he's the Vice President for the Global Sepsis Alliance. Ron, thank you very much for joining me.
Thank you for having me.
Very topical debates in the headlines at the moment, but before we get into that, would you please give us a reminder as to what sepsis is and the sort of things lay members of the public, clinicians, what sort of things we can look out for so to alert us to think, okay, well, look, we need to call for help immediately.
So sepsis is the way the body responds to infection. So it's always triggered by an infection, and it's commonly things like pneumonia, a urinary infection, or something as simple as a cut or a bite or a sting. But in sepsis, the body's immune system reacts abnormally. It's a bit simplistic to say it overreacts, it reacts abnormally. And that starts to cause damage to our tissues and organs. So the body sort of attacks itself in trying to fight the infection. And if we don't stop it, that will lead to multi-organ failure and death. Now, the first thing is sepsis can affect people of any age. And it's pretty common, actually. Sepsis affects as many people as heart attack and claims more lives than stroke, for example, in the UK every year. So this is something our public need to be aware of. The first thing is to trust your instinct. Most of us know what having an infection feels like, but if something feels very much worse than normal, and particularly if we're getting very much worse rather than better, then it's important that we go to 111 online and just ask, could it be sepsis? But if we're worried that we are seriously unwell, or particularly if someone we love or are close to is seriously unwell, there are 6 key symptoms to look for, and they spell the word sepsis. S for slurred speech or confusion, E for extreme pain in the muscles or joints, P for passing no urine, no water in a day, S for severe breathlessness, I for it feels like I'm going to die, and people really do say that, and then a final S for skin that's mottled, discoloured or very pale. Any one of those 6, not all of them, any one in the context of infection, official guidance is go straight to A&E. That doesn't mean tomorrow morning, that means now. Sepsis is a medical emergency.
I think you've summed it up pretty well, and everyone should take heed of that. And is there a separate tool developed specifically for babies and infants, or is that pretty general? Can we use that for most infants as well?
Yeah, so obviously it's difficult to give a specific age, but below a certain age, for most children it's about 3 or 4 or 5. Children do communicate differently. So of course they're not going to tell you that they feel like they're going to die, they're just going to go very quiet. So as a parent, it's really important to trust our instincts. Now, the official guidance is if a child is very lethargic or difficult to wake up, if they have a fit or a convulsion, obviously most parents would take their child to A&E if they had a fit or a convulsion, if they have severe breathlessness, if they have that rash that every parent's terrified about that doesn't fade under a glass, if their skin is abnormally pale to the touch, any one of those go straight to A&E. But as a parent, and being a bit more nuanced, you know what badness in your child looks like. If a child, a preschool child or a school-age child, is not interested in anything, won't even look at a smart device, then there's actually evidence out there to show that they're probably unwell. There's even evidence in the literature to show that if your own child won't smile when you're trying to engage with them, then that is associated with them being seriously ill. So as a parent, it's trust your gut, trust your instinct. And as a parent, you have to remember you might need to advocate for your child. For example, GPs across the country will see hundreds of thousands of children with feverish illness every year, and only a tiny minority will be seriously ill. You know your child better than any health professional. If you've never seen them this unwell before, if you're really worried about them, then again, it's just ask, could it be sepsis? And be prepared to advocate.
Again, it's making the word more accessible to people and just being brave. And I think you're absolutely correct. We see so many patients, so many children running noses and things, and it just takes that one question that if it's not mentioned, you're less likely to think of it. So I think it's a very powerful message.
And I don't know whether you agree, but I think we health professionals, and some are better than others, need to get a lot better at listening to parents. It is a very brave and foolish doctor who doesn't take seriously parental concerns.
When patients are diagnosed with sepsis, once they're in hospital and they have the timely management, what does that involve? What can we expect to be treated, and how successful is the treatment?
So we've got sort of several stages to this. We've got the package of care, which is the first aid package of care. So pretty much within an hour of the hospital recognising we've got sepsis, they should have done all of this, or at the very least most of it. So we call it the Sepsis 6. It's something we developed at the UK Sepsis Trust, and it's around getting a senior clinician close to the patient. It's around taking blood samples, looking for the source of infection, looking at how well their organs are working, giving antibiotics and thinking about getting some imaging to see if there's an infection that needs draining by a surgeon or an x-ray doctor. It's around giving intravenous fluids, and it's around monitoring the patient. So that basic package of care, it can be done within minutes, should be the first priority, and pretty much uniformly done with the first hour or so. Outside that, once those basics have been done, it's around how the patient's responding. If they're clearly critically ill at the beginning, then they should be simultaneously calling intensive care and arranging intensive care to come down and assess the patient. But if the patient has had the sepsis 6, they're not improving, or they're deteriorating after the sepsis 6, then again, they should be calling a senior, they should be calling intensive care to manage the ongoing care of the patient. Now, for people who are deteriorating, that will involve an intensive care. It might involve some very scary things for families, such as putting a patient on a ventilator, putting a patient on a kidney machine. We call this supportive treatment. It's not fixing the sepsis, it's just allowing the organs to continue to work until we address the sepsis. And then, as I mentioned, if a patient's got a gallbladder that's infected and is blocked with stones, as one example, their sepsis will not get better until we've drained that gallbladder. So care might also include surgery or a very clever x-ray doctor sticking a needle in to drain an infected source.
It can be very, very complicated depending on the situation. Now, when it comes to looking after our own health, preventative medicine, preventative measures, we get a lot of advice about not becoming obese because it leads to increased risk of heart disease and stroke and bowel cancer and all sorts. Can we predict, are there things that we can do as human beings to reduce our risk of developing sepsis following an infection? What else can be done before it even gets to that stage?
So, healthy living is a big part of it. And of course, that will help us to avoid getting an infection. It's well known that people who are significantly overweight are more likely to develop a pneumonia than people who are of normal body weight, for example. We can influence whether or not we develop type 2 diabetes to a degree. And if we develop type 2 diabetes, we are at increased risk of infection. Certain lifestyle choices can put us at risk of chronic lung disease, and that can put us at risk of infection. So there's lots of things we can do with our lifestyle to prevent the risk of infection and sepsis developing. Of course, there are interventions that can help to stop it, such as vaccines, and we've of course got the influenza vaccine, we've got pneumococcal vaccine for people over a certain age or people who are at high risk, and hopefully soon we will have an E. coli vaccine, which is really quite exciting. So I think accepting vaccines, obviously we need to ask questions about vaccines and consider whether they're right for us, but if we believe they're right for us, accept the vaccines offered to us. And then at a population level, it's around us learning. It's around the use of big data. It's around artificial intelligence, because there are at-risk groups of sepsis. Anyone can get it, but there are certainly at-risk groups. In the days of wearable technology, in the days of artificial intelligence and what the former Health Secretary Matt Hancock liked to call interoperable data, surely we can begin to learn what the trigger for a need for hospital admission is in certain patient groups and use that to get them right people to the right hospital at the right time.
You've been sort of a champion for sepsis for many years, and you've done a lot of pioneering work in developing the sepsis 6 treatment pathway and the red flag sepsis recognition tool. Could you, for the audience, just go through the history of why it was developed and how much of an impact it's made?
Of course. Well, you might be surprised to learn that actually when we started pioneering sepsis, flying the flag for sepsis, we actually had to be quite disruptive. So I started this process back in 2004. I went to the Royal Colleges, as you might expect. And one example is that Royal College of GPs turned around and said to me, well, sepsis is a hospital problem. We don't see it in general practice. We don't need to talk to you. And at the time, there were academic guidelines coming out as to how we should manage sepsis, but they weren't accessible. They weren't very sexy, and they weren't really that relevant to a busy junior health professional in an emergency department or on a ward. So our job was to take that academic stuff and turn it into something memorable. Give it a cheesy name like the Sepsis 6. And then we started spreading that and disseminating it throughout the NHS. Now, the Sepsis 6 that you mentioned, that's the treatment pathway, and we developed that first. And what it is, it's a set of 6 steps that empowers even the most junior health professional to deliver the right treatment to the patient every time. And because it's simple and because it's empowering, we're very proud to say that that's actually spread to 40 countries around the world, as well as being pretty much embedded across the NHS, including in the devolved nations. And then later, red flag sepsis came along, and that's the recognition pathway. So we had a new definition for sepsis, but again, it was not accessible. It required a full set of laboratory tests, and it wasn't that relevant to busy health professionals in emergency departments. So we distilled it, working with NHS England, working with the Royal Colleges, into red flag sepsis, which is what is now used across the NHS now.
Mm-hmm. So just over a decade on, and following the audits and things, how much of an impact has this made, particularly in the UK?
Well, we showed very early on that if we deliver the Sepsis 6 within the first hour of a patient presenting to hospital with sepsis, it doubles the patient's chance of survival. And from 2016 to 2019, we worked very closely with the NHS in England to make sure that we rapidly increased the reliability of delivery of sepsis care. And as a result, mortality in the UK dropped during those 3 short years from about 30% to about 20%. So we estimated we saved hundreds, if not thousands of lives. And then, of course, the pandemic hit. Mm-hmm. And since the pandemic, I think it's fair to say that we haven't started measuring robustly with the NHS again. And I fear that mortality has begun to trickle back towards its baseline of 30%. So there's a lot more to do.
Mm-hmm. Mm-hmm. Talking about a lot more to do. It's a good cue to bring in. What are the biggest challenges in ensuring early diagnosis, and what else can be done between the public and healthcare organisations to improve figures?
So we have to face facts. Sepsis can be really difficult to spot. And, in general practice, we see over 1 million consultations with symptoms of upper respiratory tract infection, and only a handful of those will, of course, have pneumonia and sepsis. So we shouldn't pretend that this is easy to spot. Sepsis can arise in someone of any age, of course, from the tiniest neonate through to the oldest adult, irrespective of whether or not they've got underlying conditions, and as a consequence of any infection. So the reality is that sepsis does not present in the same way twice. Everybody's different. And therefore, we can't have a sort of simple acronym like the FAST acronym for stroke that describes how most people present, because it would simply be too complex. I think, therefore, what needs to happen is we need an empowered public. We need a public who are told that if they're deteriorating with an infection, then it's okay. We empower you to just ask that question, could it be sepsis? As well as health professionals who are, of course, well trained, but also critically have the resources available and the organisational culture that empowers them to spot and treat rapidly. And part of that in both fields is diagnostics. We simply have to get the diagnostics closer to the patients. At the moment, in too many of our cities, they sit in centralised laboratories, and even though a test that can help with health professional decision making can be tested within half an hour, it's not processed for 2 days. So there's massive lags between us taking a test and the prescribing clinician getting a result. And that has to change, given that sepsis is so time critical.
Now, the UK, certainly decades before, used to be sort of the leader in healthcare, and the NHS has been the envy of the world for many years. But now that we're sharing a lot of information and practice globally, what sort of practices or what areas in the world would come to mind where you would look at them and say, this is the sort of model that should be done in the UK?
Well, I think the NHS still is the envy of the world, rightly or wrongly, given the challenges it currently faces. But of course, through my global role, I can take the temperature of pretty much every country around the world with respect to what they do. Now, it would be wrong of me to sit here and give a list of examples of brilliant practice, because I will inevitably forget one and upset a particular country. But one of the most recent that came onto my desk just last week is Switzerland. So they've just invested 50 million Swiss francs, which is around 50 million euros or 50 million pounds, over the next 5 years in delivering improvements in sepsis care. And the thing I'm really excited about is they're developing a national sepsis registry. So it's going to be based on interoperable data in hospital. They're going to bring together the lab data, the vital signs data, the demographic data, and everything else, apply artificial intelligence to it, and start to understand better what sepsis looks like. And that will help us both to recognise individual patients more quickly, but also it will help us to learn which patient needs the most urgent antibiotics and in which patient it's safe to wait for a few hours until we've got a bit more information. That's really exciting.
So bringing diagnostics closer to home, whether it's medtech and smartwatches and the use of AI, where do you see things going in the next few years, particularly for people trying to get help as early as possible, members of the public?
I mean, the potential is hugely exciting, but let's face reality. The science and technology is evolving at a much more rapid rate than our ability to integrate it into healthcare systems. And, I'll use an example. During COVID-19, we had the ARI hubs, the acute respiratory infection hubs, that would enable us to detect viruses in respiratory viruses in patients very quickly, send them to the right place and advise on the right treatment. Now, since COVID-19, they've largely been stood down. Why? We have all these fantastic diagnostics that can help community specialists, GPs and community nurses to really understand whether a patient needs antibiotics, which antibiotic they need. We have rapid diagnostics for all sorts of things, including antimicrobial resistance. So the ARI hubs would have been a great starting point to bring that technology closer to the patient, empower prescribers in the community to withhold antibiotics when they're not indicated, and allow them to give the right antibiotic to the right patient. And a real bugbear of mine on that is that there's massive inequality in antibiotic resistance. So some of the best data is from Leicester. If you're in Leicester, if you're from an area of low socioeconomic deprivation, the Wigstons, the Obies of this world, the wealthy areas, you've got a 40% chance that your E. coli will be resistant to the first-line antibiotic. And as most people will know, E. coli is a really common cause of UTI. If you're from a poor area, it's 80%. So surely we need to empower prescribers in those communities to know which patients can have the first-line antibiotic safely and in whom we need to go straight to the second or even third line. We've got to get this right. But back to the question, wearables. At-risk communities, I think increasing our ability to harness wearable technology. A lot of this stuff that we're measuring on our smartphones now is actually becoming a Class 1 medical device. And so it's as good as hospital-based diagnostics. And so we need to harness that. For high-risk groups, we can monitor patients in the community. We've heard of the hospital at home. I think that side of things will massively explode, and we've got to use artificial intelligence, pattern recognition, to enable us to do so safely.
Talking about antimicrobials, so you've worked extensively on ensuring rapid antimicrobial treatment. for sepsis, whilst also acknowledging the concerns for our consultant microbiologists and about resistance. In a nutshell, if we're trying to, I struggle to explain to patients sometimes about why I don't think you need antibiotics today. I may get a blank face or a frown saying, this is what I need, this is what I want. Doctor gave it to me last year for the same thing. In a nutshell, how do we can we explain better what antimicrobial resistance is and how best we can use evidence and treat people effectively and appropriately?
I mean, I think that a lot of people, when they are unwell with an infection, they make an assumption that they need antibiotics, and they go to a prescriber in primary care or general practice, and they have an expectation that they're going to be given antibiotics almost to validate their illness. They want to go home and say, I told you I was ill, darling, I've got these antibiotics. Well, what if instead we said, I told you I was ill, darling, the doctor did a special test and it says I've got a very bad virus. Again, diagnostics have a role to play. But I think also the public haven't heard the right message about antimicrobial resistance. Massive credit to Dame Sally Davies. She's raised the issue on governments' agendas around the world more than anyone else on the planet. But our public have heard that they might not be able to have a hip replacement in 50 years' time if we don't act now. And that's intangible. It's not immediate. It's not personal. The reality is, as you will know, there are people in my hospitals today, in their hundreds, who have antibiotic resistant infections. And every now and then, even today, I am faced with people who have an infection that's sensitive to only one antibiotic. So it's here now, is the first message. The second message is actually taking antibiotics is bad for you if you don't need them. Yes, we all know that they can cause diarrhea and other unpleasant side effects, but actually there's good evidence that if someone has a dose of broad spectrum antibiotics, their gut flora will never recover to normality for the whole of their lives. So there are increased risks of infections, gastrointestinal problems, and so forth. So you shouldn't want antibiotics unless you really need them. And then I think the third message is what we can do about it. And yes, we can reduce antibiotic expectation, antibiotic seeking behaviour, but it's also about consumerism, because 70% of antibiotics used are outside hospitals in humans, and more than half of antibiotics used are actually used in our food chain, not to treat humans. And a lot of that is driven by our desire for large volumes of cheap meat, essentially. Intensive farming consumes huge amounts of antibiotics. And from a consumerist perspective, if we could go back maybe to the 1950s and say, if we choose to eat meat, let's have it as a luxury on a Sunday, let's make sure we get it from a reputable source, then that can do a lot toward slowing the use of antibiotics in intensive farming, stopping the consumer pressure, and slowing the rate of antibiotic resistance. So I think there's new messaging needed for our public.
That's very, very interesting. Do you think we're certainly seeing the increased use of antivirals, particularly for COVID infection, influenza? Do you think culturally there'll be, like in the States, I think antivirals are used pretty commonly. Do you think culturally there's going to be an increased use of antivirals, if appropriate, going forward?
Well, I think there will be. And one of the good things about the antivirals use during COVID in many countries was that it had some evidence base. So, for example, in the UK, we would use them in the community to mitigate the risk, to reduce the severity of the infection and stop people having to go to hospital. But once they were in hospital, we learned that they no longer worked. This was now an inflammatory problem. It wasn't because of overwhelming viral load. And so we didn't use, certainly once they came to intensive care, we didn't use antivirals. So I think as long as it's evidence-based driven, it's appropriate. It can improve productivity, it can improve the workforce health, and so it's probably the right thing to do. As long as we accept that resistance is a natural evolutionary consequence of any antimicrobial that we use. And so viruses will become more resistant if we do.
Oh, gosh. Let's talk about the global fight against sepsis. So it still remains a huge global challenge, and you played a key role in the World Health Organization's 2017 resolution on sepsis. How have international policies evolved since then, and what further steps should be taken on a global scale to combat sepsis more effectively?
I mean, some countries have done really well. So one thing that the resolution we presented to the World Health Organization, which they then adopted, said was that countries had to produce national sepsis action plans. Now, I've mentioned Switzerland, but many other countries have done it. The Austrian have, in Europe, Austria have one, England has one, France has one, and so forth. We've got Pakistani national sepsis action plans. Some of the Arab countries have developed national sepsis action plans. And then, as we know, in Australia and in North America, things are regionalised to states, and many of those states have their own national sepsis action plans. So that's great. But of course, there are nearly 200 United Nations member states, and it's only really the higher income ones, with some small exceptions, in which we've seen transformational change. Some countries were trying really hard. So Sudan, would you believe, did some incredible work regarding improving outcomes from sepsis before the conflict really took hold there, and they're very keen to reinvigorate that. So we've seen pockets of brilliance, but we now need funds and resource applied to this. Now, that may not come from WHO, but given that sepsis and antimicrobial resistance are intrinsically intertwined, given that antimicrobial resistance, even according to Sally Davies, is a more immediate existential threat to humankind than climate change, surely we need the likes of major international philanthropic organisations to support countries who don't have their own resource to do this really well. Because the reality is, yes, sepsis is a massive problem in the UK, Europe and the US, but there are 11 million deaths from sepsis every year around the world, and half of those deaths are children under 5 in resource-poor countries.
Bringing things back to the UK, something that we can't avoid because it's been in the headlines, the term corridor care is being coined all over the place. And we know it's not a new thing. Patients have been very sadly being cared for in corridors for over a decade, but it's reached a crisis point. And one of the most important things to do with treatment of sepsis is timely care. So within an hour, according to the protocol. What's happened? What can be done? What are we going to do?
Well, I mean, isn't it a sad situation that in this day and age, the official message is if you're ill and you think you've got sepsis and you can get yourself there safely, go straight to A&E. So the message is no longer call 999 unless you have to, because there are going to be delays. Sepsis is now a category 2 call, meaning that we don't have this target time of just a few minutes for the ambulance to get to you. We accept a target time of, in busy periods, a few hours. So already the clock's been ticking. And then the second, when did it become normal? When did it become acceptable for patients to sit untreated in ambulances in large numbers outside the emergency department for several hours at a time? That's clearly not acceptable in a modern healthcare system, yet we just seem to have taken it. It's just arrived insidiously, and it's now, seemingly an accepted part of practice. So it's not surprising that once people do get through the door, there's corridor care. So what's driving this? Is it acceptable? No. What's driving this? I mean, a politician would tell you that this is about a growing population, it's about an aging population, but, someone a bit closer to it might say, well, we're doing more and more invasive things to older and sicker people with alarming regularity. And I think as an intensive care clinician, and I hope a very compassionate intensive care clinician, I think we need to begin to have grown-up conversations with our public about expectations in advancing years and toward the end of life. Because the expectations of families, of patients, if they're competent to talk to us and make decisions, and even some of my clinical colleagues are very, very high toward the end of life. They say, well, let's try putting them on a ventilator, see what happens. Well, I can tell you what's going to happen if I put a very old, frail person on a ventilator. They'll either die very slowly in hospital, or they will return home, often to a nursing home, to a quality of life that they can't enjoy. Now, is this the right thing to do to that patient? Or would it be more compassionate and kinder to palliate such patients? But I've seen this creep in my 20-odd years as an intensive care consultant, that we are subjecting people by intervening to lives that are very dependent on others, and often to lives that people don't value all that much, by their own admission. We should never judge someone's value of life. But we need to have these grown-up conversations. We've also got to do all of the other things. The ambulance service, waiting times to get an ambulance to the home are huge. But you watch the programme on the BBC, Ambulance, and you see that too often they're sitting for 2 hours dealing with social problems in patients' homes, and they're there as an, they can't be an emergency service if they're dealing with social care issues. So we've got to improve social care, we've got to improve mental health care, we've got to improve cognitive care, we've got to improve the availability of intermediary care facilities within our community, step-down facilities and social care. Because until we improve the flow through the system, things are only going to get worse.
I think that's all very fair points, and certainly, a lot of the challenges arguably were not met in the last 15, 20 years. The new government, Labour government that's just come in, they've got a huge challenge over the next 4.5 years. Practically speaking, in your opinion, are there any quick wins or certainly tiny wins that can be done over the next few years that could probably really improve the situation?
So I don't think there are any quick wins. And I think it's very easy, particularly for younger colleagues who've really only practiced during a Conservative government, to say everything is a Conservative government's fault. And, as someone who's practiced in successive Conservative and Labour governments cyclically, I can tell you things don't get better under any one particular party. And I think the one quick win that we really could make, I can talk about quick wins if you wish regarding sepsis, but in terms of the NHS, I think we need to take this outside party politics. We need a group of senior statespeople from all political parties convening, not as a task and finish group, but as a continuous advisory and steering group to decide how the NHS should operate, what we're going to prioritise within the NHS, what we're going to deprioritise, whether indeed we need to think in some sectors about rationing care, and, really to take those grown-up decisions, because this is serious now. This is not something that a few extra million a year are going to fix. This is a broken culture and a broken system. And I know from a corporate perspective, I'm not supposed to say that things are broken in the NHS. The NHS is a wonderful institution, but it is frankly not delivering the care our patients deserve any longer, and we have to change that.
Mm-hmm. And then bringing it closer to home, sepsis, what can we do to save more lives quickly?
Well, when the Right Honourable Wes Streeting first came into his role as Secretary of State for Health, of course, as you would expect as an advocacy organisation, we presented 3 quick wins for him. Now, if you'd asked me how many people get sepsis each year, I couldn't tell you. I can't tell you. There are no good data around sepsis. So quick win number 1 was mandatory, publicly reported data on number of admissions with sepsis and outcomes at a hospital trust level. So that's quick win number 1. Quick win number 2 is around the diagnostics. And you will know that a big barrier, let's say you found a diagnostic really sexy and interesting and you thought it was going to be useful in your clinical practice, you're not really empowered to procure that diagnostic. There's lots of barriers in your way. So to work out mechanisms by which health professionals, whichever their clinical setting, where it's inside or outside a hospital, can procure and safely test diagnostics and integrate them into clinical practice to help us to deliver the right care every time. And then the third thing is the routine provision of what we call safety netting information. So essentially, somebody goes for a consultation, we say to them, we think you're okay, you can go back home, but here's some information about what to do. So routine signposting to safety netting information, together with routine signposting for survivors, because long sepsis or post-sepsis syndrome is just as much a thing as long COVID, to rehabilitation and support services. So those 3 quick wins of what we've presented to Wes Streeting. As yet, we've not heard a lot back, but I think those 3 actions would really improve the quality of care. And what we're doing from our side, and this is hot off the press, is we're about to launch a Class 1 medical device that will sit on our website. And we know that people have heard of sepsis. We know that people recognise sepsis as a medical emergency, but we've now been working with an organisation called Health Hero, who put together a Class 1 medical device based on accepted symptoms lists so that people can go to our website and they will be told. They'll put in their symptoms, they'll go through the questions. You need to go to your GP, you need to go to 111, you need to go and see a pharmacist, or you need to go to A&E.
I think it's fantastic. It's exactly the sort of thing that next question would have been, is there some sort of integrated care pathway that everyone can access to almost fill in the bits they need to help make a decision? So I think that's wonderful news.
Well, it is, and sorry to interrupt, Atif, but integrated care is exactly what this needs. This needs the commissioning boards to actually be able to commission for excellence, to be able to recognise. We've seen the stroke model that's, yes, it's not functioning quite as well as it used to, but the stroke model that became embedded across the NHS over the last 15 years, where, commissioners would expect that we would be able to thrombolyze, would expect that we would have access to hyperacute stroke units. Why doesn't this exist for sepsis?
Now, just final question. This is to do with CQC, compliance organisations. Is there enough joint collaborative work when it comes to regulating healthcare organisations in conjunction with preventing sepsis, effective infection control? Do the organisations speak to each other as effectively as you think they should?
Well, no, while we work with the CQC and do work with NHS Resolution, and we advise them on the sort of questions that they should be asking and advise Resolution on the sort of things they should be looking for when a complaint has arisen, there isn't enough joined up thinking. So a few years ago, I developed a new organisation called the Infection Management Coalition, and it says exactly that. It says that governments at a policy level need to start to consider infection management as a whole. So that will include outbreak surveillance, pandemic preparedness as one pillar, rapid treatment of sepsis as a second, infection prevention and control as a third, and antimicrobial stewardship as a fourth. And we shouldn't have different departments doing different bits of this. This is all in the business of preventing harm from infection, and so we have to do it holistically. And in terms of the delivery, at the risk of repetition, I'll come back to, this has to be devolved to regions, perhaps to ICBs, and they have to be prepared and empowered to commission for excellence in the prevention and management of infections.
A fantastic conclusion. Ron, thank you very much indeed. And I really hope the powerful, influential organisations that we've all mentioned take heed, and that a lot more is done to prevent deaths that can be prevented. So thank you very much indeed.
Well, thank you so much for giving us this window. It's really important.
If you have any questions, feedback, or you'd like to learn more about how we can help your organisation, please don't hesitate to get in touch. Our contact details are in the description below. Don't forget to subscribe to our podcast for more episodes and updates. You can also follow us on LinkedIn, Facebook, and Instagram. Once again, thank you for listening or watching, and see you soon. We are the Health Group. We work with new and existing healthcare providers every single day, from private clinics to adult social care services and NHS trusts, to ensure all providers are compliant with regulations, have a culture of excellence, and are delivering exceptional care.